Sarah Coll. I'm an orthopaedic surgeon based in Cairns in Queensland, and today I want to talk about Workcover Patients, and I want to direct it as primary care providers to try and help them understand the Workcover process, because there can be a few bumps in the road, and sometimes it's just nice to have a little bit of an idea of what the whole pathway is going to look like. So today I'm going to talk about why I take the role of patient advocate. So a patient advocate is the person who is able to speak on behalf of a patient to an organisation, and I have done that for my career and I really enjoy that role. But I do have a conflict of interest when I talk about Workcover. So there's two things I've done. The first is I am part of what's called the Workcover Tribunal, which I will explain at the end of this talk from 2020, and I currently perform that role. And I also in the past have done what's called independent medical assessments. So that's assessments by a doctor of a patient to facilitate a legal process. So the first thing I like to talk about when I talk about a Workcover claim is really narrowing down what the injury was. And I think in the heat of the moment, the patient is often quite agitated, they're a little bit distressed about the experience, they've got some concerns about their injury, they've got concerns about the mechanism, and they kind of want to tell you all about the experience with Workcover, but they struggle to narrow down their focus back onto the injury. So I try and get them to tell me when the injury happened. For a Workcover certificate, it doesn't always have to be perfect. It's important to get an attempt at the date on the certificate, and you can go back and change that. That's not final. I also like to tell them that I need to hear about a specific mechanism. So I need to hear about how they injured it, what they were physically doing at the time, and I even get them to stand up and show me how the injury happened. It's important that the patient understands that in Queensland, the insurance process is not very effective at covering patients having had long-term recurrent overuse injuries. The insurance claims for those are not as successful. This is about treating patients who had a specific injury on a specific date in a specific location, and that's what the insurance is for. We talk about the mechanism of the injury. So Workcover, as an insurance body, wants to understand both the specific anatomical nature. Hello, come on in.
Sorry.
No, that's okay. I did say bad things about you in your absence. I did say bad things about you in your absence. So I try and pin them down to that Workcover have an obligation to determine what the mechanism of injury is. And I try and explain that to the patient in that they don't just need the mechanism, they need to know if there is something that they should be doing to prevent this injury happening in the future. So it's not just a matter of finding someone to blame, it's not a matter of causing the patient any distress about trying to describe it. It's about trying to narrow it down to the actual energy, the speed of the accident, the height of the fall, what sort of forces have gone through the patient's body. And then we are expected on the medical certificate to have a comment about whether or not we think this mechanism that they've supplied as the explanation of their injury matches the anatomical diagnosis that we have. And we have a little tick box for that, yes or possibly not. And then I always like to, when I work on tribunal, we do actually narrow down to when they stopped work. So were they able to finish that shift? Did they do several weeks more at work, or was this something that they were whisked off in a helicopter to the major hospital? So when did they actually stop work, and what made them need to stop work? So they injured themselves, they hurt their shoulder, and 2 days later they tried to lift something and they just knew they couldn't keep going. And then sometimes I need to understand, I try and allow them to tell me if they're suffering some significant financial distress. So sometimes the claim is not being processed very effectively, and I can see why the claim is not being processed. There's been a gap in the process, and sometimes the patient is already dropping into significant financial difficulty. So I do try and address that indirectly. So I try and make sure that they're not in a significantly difficult problem, but if they are, I then try and work out where have they fallen off the process, where did this come unstuck. So once again, initial certificate, date of injury, best guess, mechanism of injury, I try and be clear about what the patient has described. The steel roller weighed 500 kilos, it crushed my finger. My finger was between the door and the handle. Show me a picture, they'll show me a picture of the handle. Oh, okay, that's how it got crushed. I like, when we describe the injury, it's helpful, particularly, this is difficult for general practitioners to actually define the anatomical term. So shoulder is helpful, but supraspinatus tendon is better. It's important that you don't have to be correct about the anatomical diagnosis, but I think there's value in trying to include some sort of attempt at an anatomical diagnosis. You've got an ultrasound that shows there's a supraspinatus tear, there's a trigger finger, that sort of thing. I think that is helpful, and it helps me direct the claim, and then also helps the caseworker direct the claim and facilitate treatment of the patient. It's nice to tell me if it's left or right on the initial certificate, tell the caseworker. There's often a bit of confusion. It's nice to check that with the patient when they're still in the room. And then sometimes they actually will come back later and say, oh no, it was always bilateral. It's a bit late if they don't say that at the beginning. And then other sites injured, particularly at the end of a claim, it's not very helpful if no certificate ever said that their right foot was injured, and now we're at the end of a claim and they've got a right foot injury that hasn't been included. The thing that I try and say to the patient is that they are ultimately the one that is expected to contact Workcover Queensland. So on the bottom of the certificate is in teeny tiny numbers is a 1300 number, which is difficult to get an answer on and can be a frustrating process, but the patient needs to initiate the claim. The employer is not required to initiate their claim. So the patient will often say to me, oh, I told my boss that I wanted a Workcover claim, I gave my boss the certificate, and I say you have not initiated a claim. Some patients, and we talk about this a little bit in my clinic, some patients have difficulty with language, so sometimes English is not their first language, sometimes they do have difficulty with reading, and sometimes they have difficulty with writing. So they need to use an advocate or a support person to try and help them with that process to make sure that they can get that paperwork submitted. You don't ever do certificates, do you?
No.
Do you ever have problems with certificates?
Lots of problems.
And what's your number one problem with certificates?
They're vague, and sometimes
not got the anatomical side. Is that what you mean?
Yeah, they might have something that's not even that relevant anymore.
Go on. You mean something that was a problem initially and is?
Yeah, I think sometimes they might write an anatomical thing. Like example one, and this is just from a long time ago, it was like trap tear, and it wasn't a trap tear, but they would assume trying to be
anatomical.
Yeah. And then the person was really concerned about a trap tear.
Oh wow!
Because that's what's on the medical
yeah, of course.
And then when med certs change, as they learn more things that it actually is, there's always in their mind, but this thing, because it was on the nerve cert.
On the initial certificate.
At some point in time, is sometimes.
Yeah.
Other things I have is that
well.
the poor doctor doesn't really have a good understanding of what they physically can do. So they will be quite conservative.
Correct.
On the medical certificate,
yes.
And the patient is terrified because they've been told you can't lift anything that's more than 500 grams.
Yes.
And yet they're doing it every day in their life.
And what are they frightened of? They think they're going to hurt themselves.
They then think that that's not safe anymore.
Oh,
at
interesting.
Home. So then they stop even doing it at home. And things like that.
Yeah, so I don't think I've got a slide on suitable duties, but that's a really good point, is trying to work out what they can do.
Yeah.
So sometimes we have to say, what did you do with the physiotherapist? And they don't know.
Yeah. So what I'll need to communicate to them is that we do things that are above what will be on their med cert in our sessions.
Yeah, nice.
In a controlled environment that is different to in work.
Yes.
And then they can get confidence in that.
Yes.
And then we can say to the GP and the customer advisor, they can do this. And often it'll be slightly less of what their absolute maximum is.
But I had a patient just the other day who was stuck on 1 kilo lifting limit at work, and the physiotherapist hadn't progressed them. And we said, well, that's the place to progress your weightlifting because you're being supervised and you've got a professional.
Oh, as in exercise even, they haven't.
The physio and the patient had stopped at 1 kilo, 3 months after a shoulder operation because they had
because of the research.
Yeah.
Oh, okay.
Right, and so they missed you can try it. I said, don't try it at home. Lift 20 kilos at home when you're trying to, push the boat. Don't try that at home and hurt your shoulder. Do it with a professional that we can document if there's been a problem.
Yeah.
At least then you can recognise early, you can refer early, and we can, it's a controlled environment and they're not injuring themselves at home. The other thing with suitable duties certificates is I try, but I do not really understand their job.
Like
the
all the tasks they need to do.
When he says he's a diesel fitter, there's a difference between a diesel fitter and a diesel fitter.
Yeah, the different roles that they do.
Yeah, so if I've got to try and match it into that's quite a long conversation. We've got to kind of try and find out what they do and then try and find out whether or not it seems appropriate. And how do they know if we would think it was appropriate without that conversation?
Yeah.
For suitable duties.
And really, if a suitable duties plan is being done, a rehab consultant is helpful.
Yes, we do a functional capacity assessment
the job
as well.
task analysis to give all of that kind of crystal clear.
I do appreciate that. When I get a bit stuck,
like if the employer is quite rigid and they don't have easy solutions for some suitable duties, then a rehab consultant can just.
I read something about tennis elbow and it said autonomy is the quickest return to work. So if the patient can go into work with a sense of autonomy, a sense of being able to make the decisions about whether or not they are safe to do a task, and not feel obliged to do something that they know they can't do, then they do actually progress through the process much faster. So that's why I try and have the conversation with them. What do you feel confident about doing? What do you know you can do? What have you tried that you know you can do? Oh, I can lift 500 grams. Can you lift a coffee cup? Oh, yeah. They get very reluctant to say that they can use their arm at all. They're frightened.
Yeah, and there's not enough space on the med cert to give the nuance that's needed, and that comes back to the vagueness of health professionals like, oh, they can't do that at all, as opposed to that's within the work. It's just we can't control how much they're going to do with that, how long they're going to do it for. So let's just cap it at this, so they can't possibly injure themselves. If they do heaps of below that. With a suitable duties plan, so with a rehab consultant, I'll communicate with them. The part of their rehab is going above what's in the med cert, in work within limits. So in the suitable duties plan, they'll put in that it's their limits for, but there's opportunities for them to go above where they feel confident and comfortable up to 6 kilos. And then and that's kind of that autonomy that they have because part of exposure is they're terrified. Let's see what happens. It's okay. It's fine. But if they're always just staying at that level, in that environment, it's harder to actually build it up. So a few rehab consultants have done that lately, and it's huge. Because then because they get really worried doing above their limit. Because they're breaching. And then it's also like the fear of stigma. Oh, you're putting it on because your doctor says you can't do this, but look, you can do it.
Oh, no.
And they're like, oh, but I can do that with the EP or the physio. It's like, and so there's so much. Back of house stuff that's.
And also things like when they've got to get up into a vehicle and they need those 3 points of contact and they know they haven't got 3. Just little tricks that they've got that they take for granted that they should be able to do. So first consultation, I take the history again, and then sometimes what they're looking for when we do the tribunal is the consistency of the description of the event. And of course, as you know, when you replay a story, sometimes they get it, well, personally, my stories get a little embellished, but it's hard to tell the same story exactly the same way every time. So I do ask for a little bit of repetition. I say, oh, I've forgotten how, what happened, tell me again, and then I sort of check back are they actually saying something that sounds similar to what they said before? Sometimes they get, the side wrong, oh, I fell, this way, and then they think about it, oh no, actually I did fall across like that, They just sort of get tangled up and land on the ground. They can't quite remember exactly what happened. Previous claims, sometimes it's helpful to understand if they've had this experience before and what it was like, what they ended up with, where they ended up with their claim. They're uncommon, but sometimes it will set the sort of tone for how they want to run this claim. They come in with a bit of confidence, they've dealt with caseworkers before, they know how they want to manage the process. Once again, examination is a little bit about consistency. So if they see you and they've got very limited range of motion, or if I get a report back from a physiotherapist that shows me a beautiful range of motion and they come in and they've got very little, it's important that we then have the conversation about, do you understand why your range of motion might be different? What do you think's going on? Because sometimes the range of motion that they want to show me is more in alignment with what they expect to be able to do at work and what their concerns are about work, and they're trying to express their concerns about a return to work. And then also I then have to check the consistency of the investigations with the mechanism of injury, and that's a important expectation of a specialist by the caseworker. So they do want to know if we think that the mechanism and the injury and the investigations and the physical examination are all in alignment. And I think this is where the doctor-patient relationship becomes a little bit more fragmented, and I find it quite challenging in that I'm trying to prove something to an insurer. I'm not just a care provider, and so I think it once I get that, once I've decided that it's all consistent, then I just park that and we just focus on treating the patient and treating the injury. But I try and lock that in the first consultation. How did you do it? What's going on? What are we doing? Lock that in the first consultation. Once I've decided this is a compensable injury and this is the injury that we've got, then we treat the patient from that, so that it doesn't carry over into the subsequent consultations as much. I always try and encourage GPs to do X-rays and ultrasounds. Sometimes patients or, sometimes people think, oh, it's a waste of time, I should just get an MRI scan, which is lovely, but sometimes the MRI scan, when they do the MRI scan, they do change the settings. So I've had patients who have had to go back and get repeat MRI scans. So they've done the shoulder, but actually it was a sternoclavicular joint, they haven't quite scanned all the way across, pec major, sometimes they don't always scan all the way into it. And sometimes if there is a risk that there might be some sort of tumour, then you want to have contrast, or if you think there's some sort of subclinical fractures and things like that, sometimes contrast is helpful. So it's not always a huge benefit to have the MRI scan before the initial consultation, unless they're clearly a meniscal tear or clearly a supraspinatus tear. So I don't always encourage it. An MRI scan prior to appointment. I do like imaging prior to an appointment. I think I should do more blood tests. So I think I should look for rheumatological conditions more than I do. I think my threshold is a little too high. And the one that I can remember most recently is the bilateral carpal tunnel. Comes in, bilateral carpal tunnel, hands and fingers are very stiff and very sore and very swollen. And she had an acute onset SLE. So she needs to see a rheumatologist quickly. She can see an orthopaedic surgeon. I can release her carpal tunnels, but I'm not actually going to do anything about her tendonitis. And she actually needs treatment for her underlying condition. So even in Workcover patients, I think the blood tests can be helpful, because if you're dealing with an acute rheumatological presentation, they need to be diverted into the appropriate treatment. So when they see a surgeon, I always supply a Workcover certificate at every appointment, and then I supply a certificate that lasts them until their next appointment. And so I try and cover that time frame. I do try to explain to them that if there's a problem in the meantime, they can come in before that certificate runs out, but they don't always understand that that door is open. They feel like they've got to wait sometimes. So I do try and reinforce that sometimes. Discuss the mechanism of injury, as I said before. I frequently will get a request for what's called a comprehensive report, which asks me, when is the patient going to be better? which is a challenging question, I find. It also asks me, is the patient stable and stationary? So this is at the initial consultation. Have they had maximum treatment? Can we close the claim? And the answer is, let's do some investigations and see how we go. I am expected by Workcover to try and create some sort of long-term treatment plan and the time to recovery, and particularly with shoulders, I start feeling out, can you go back to work in a sling? Can you go back to work with limited arm movement? Can you go back to work? Do you have a heavy physical job? Is this your dominant arm that you've got to swing on a hammer? If they work for council or they've got a heavy manual job, I warn them you might need a year off work. Okay? And so I try and start with that so that they're not kind of badgering me at 6 months saying, what is wrong with me? Why can't I do heavy manual work? Some people can, and I have had some beautiful, the poor guy could lift 20 kilos at 3 months. And so people do it, and I'm very happy if they do, but I just warn them that if they're unhappy at 6 months, we're just going to keep waiting, And then I try and say to them that there is an element of self-efficacy. So after I've operated on them, I can't do their exercises for them. So they need to work out what's right for them and what they're prepared to do. Identify the red flags. The things that kind of worry me are if they've lost their job already. So sometimes that's not necessarily related to the Workcover claim. It's particularly challenging if it's associated with drug use. So they've lost their job due to drug use in the sort of peri-injury period. That's a very challenging one to get them back to work. The relationship with the employer, if they perceive that they have a negative relationship with their employer or they're disrespectful in their language around their employer, I'm concerned about that. If their history, if they've had injuries before and they're very familiar with Workcover systems, they come in with very clear expectations. They've been treated by a different surgeon. They've got very clear expectations of how this process rolls out. And then I put in their cultural expectations. I think we live in a very diverse community, and I think I have cohorts of patients who have expectations of themselves outside work that they cannot let go. I have cohorts of patients who expect injuries to have a certain pathway that I don't appreciate because I'm not in the same culture. And then I think trying to learn the language of how they're expressing their experience is also really important for us as practitioners to try and understand how they're telling me. So some patients can get quite emotional and dramatic about their injury, and I find that quite confronting. I kind of get involved in the emotional experience, and I have to try and separate myself out and try and listen to what they're trying to tell me through that emotion. And I often try and get them to dial it down because I find it confronting. I have to sort of ask them gently to sort of wind it back because I can't focus on the job when they're having a heightened experience. So we do talk about that a little bit. MRI scans, nice for anatomy, as we were talking about before. I do think that there is a benefit to the surgeon looking at the scans. I know radiologists are fabulous, but I think sometimes when you can poke the sore bit and look at the picture, I think that really adds an element of injury management that I think just reading a report is not quite enough. Pre-existing degeneration does not void your cover. And I try and say this to patients. Patients will have a pre-existing knee arthritis, pre-existing shoulder problems, pre-existing concerns. And I try and say, if we didn't want to cover pre-existing conditions, we couldn't really employ anyone over the age of 18 because we've all got something and we can't not be covered in any circumstance. So what they're really looking for is whether or not the workplace injury has contributed to the deterioration in a significant way. So yes, they had a little bit of arthritis, but now they've got a terrible meniscal tear that was clearly not there before. We've got old scans, they've got a meniscal tear. Is it reasonable to address this new meniscal tear? And it does actually become relevant when they get a payout at the very end of their claim. If Workcover goes to give them a payout and they've got a pre-existing condition, they remove the contribution of the pre-existing condition to that payout. That doesn't mean they miss out on all their treatment along the way. It just means at the end they miss out on some of the payout. So I don't think, so patients can sometimes get caught up in pre-existing degeneration, but it doesn't void their cover. I then generate a surgical decision, and that requires what's called a hospital request. So I submit another piece of paper to Workcover, which will tell them about when I expect the patient to get better and what the post-operative treatment plan is. I've made a note about joint replacement. There are some states that have different legislative requirements about fitness and return to work and recovery. Queensland doesn't really do much in the way of joint replacement, so this is patients who've had such a significant deterioration that they require a joint replacement, but we submit a hospital request. I then book them in for a follow-up appointment 4 weeks later to try and make sure that they've been able to process that request. And I would say probably 1 in 100 patients has missed something. You know, they thought they'd put the piece of paper in, or they thought the caseworker was recognising that, or they missed an appointment with the IME, or the reviews didn't happen. So I bring them back at 4 weeks just to make sure that things are rolling. Post-operatively, I talk about therapists, and I think, and please, I'd love your feedback, I think Workcover uses therapists to keep the patients to account. They make them turn up once a week, we look them in the eye, you know, how are you going, what's going on? Do you think that that's a helpful thing for a Workcover caseworker?
I suppose it depends on the intent behind it. Is that to help them in their recovery, or is that to try and
I think it
cut them off?
No, I don't think it's to cut them off, it's to make sure they're engaged,
okay.
I think.
Then that's
you know
great.
what I mean?
Whereas if their intent was like, you know,
You're not engaging somehow.
You're not engaging in the recommended treatment, therefore.
I mean, look, that does happen.
Yeah.
But I tend to find that happens because they can't get transport, or the treatments. The hand therapists in Cairns and they live in Dibula.
Yeah.
You know, and that's trying to explain why that's challenging is important. But I think sometimes they want you to see them to make sure that they are actively involved.
Yeah, and that's helpful. Very helpful.
Yeah, good.
Yeah, and our job is then to try and empower them to do as much as they can without us.
Yes.
But then sometimes we can't do that if they don't turn up. So
yes, agreed.
To say, hey, you need to attend your appointments is helpful, in my opinion.
Yeah, I agree. But even letting the caseworker know that they haven't been able to attend, I find that's helpul.
Yeah,
because if I see them
barriers and
if I see them 6 weeks later and they've done 2 physio appointments and absolutely have been too frightened to get off the couch the entire time, well then I need to rethink, maybe rescan, what have we missed. And then in the post-operative period, so I've got motivation through the unfamiliar process of rehab. I don't know if this has been your experience, but I feel like some people are used to going to the gym, they're used to doing training for their sport, but they've never necessarily had, the hurdles that come through in rehabilitation. I always feel like it's 2 steps forward, 1 step back, and emotionally that must be very frightening when it's a Workcover injury.
Yeah.
Sure, you injure yourself doing some crazy thing like falling off your bike, and that's on you, but if it's a Workcover injury and you have a setback, that must be challenging.
Yeah. And I think the thing that I notice the most is people go, I've never not recovered from something before. So I see them when they haven't gotten better.
Yeah, true.
I haven't seen it acutely. I see them when physio hasn't worked. They're like, I always get better and I haven't this time. It's like, well, it's not a coincidence that all the other times it wasn't work related. Because like evidence shows that if you injure yourself at work, the same injury at work takes longer to recover than when you're not at work because of all the factors at play. So that's often what I hear, just that kind of sense of confusion and frustration, like I am a healer. I am their identity's being challenged. The crisis about they're getting older now because they want to heal. That's all that.
I don't want to hear any of that. Now I'm getting older, I don't want to hear that from a patient because they're always younger than me. But I agree. Yeah, it is unfamiliar to them, isn't it?
Yeah.
It's a different process.
Yeah.
And we take it for granted because we're doing it all the time. I try and show them the difference between muscle pain and joint pain. Even when I do the ultrasound, I do an ultrasound of all the rotator cuff repairs and I rub over where the stitches are and I say, this is the bit that I don't want you to stress. You can do whatever you like, but if you're stressing this bit that, like I show them, I don't like hurting them, but I'm trying to show them this is the bad pain And everything else you're complaining about is like, la la la, can't hear. Because I want to know if they're overstraining their repair. And then once they start, particularly for a rotator cuff, if they start developing all those dysfunctional movement patterns, then that's always a trigger that I'm worried about the repair. I then review the timeframes and modify as required. And I personally tend to follow up all patients right until the end of the claim. But obviously I can do share care, and some caseworkers prefer if I don't see them, and some caseworkers like it if I do. I just stick to that policy. We have a nurse who, Kelly, who I find is very helpful for me. She asks, according to a checklist, how much pain do you have? Where is the pain? How many out of 10? What pain relief are you taking? Are you still smoking? How much are you smoking? When did you go back to work? How is it going back at work? And she can give me a full checklist of all of those concerns. She can direct the patient's attention to the information that we need in order to facilitate their claim. And then I can come and see them and say, okay, what is our strategy here? Where are we going? So yes, I do tend to follow them up. Closing claims. Some states expect a closing certificate, so they're required for me to say, the patient is fully fit, or they can't let the patient go back to work. In Queensland, I can let a certificate run out, and the claim will automatically close. So I can say that I don't need to see them again, but they need 5 further physiotherapy appointments, and they're fully fit, right? So that allows me to close a claim without a final review, but I frequently do a final review. I just say, come in, show me what you've got. Are you happy? Is this claim, resolved according to you? The caseworker can facilitate a closure. So they ask if they're worried about a patient, they'll ask me some key questions like, are they still achieving gains with the therapy? So they need to see if the range of motion is increasing with a physiotherapy session. They don't need to see it every single physiotherapy session, but if you're required to supply a report, they need to see that their flexion went from 100 degrees to 120 degrees over a 5-week period in order to continue to fund it, right? And that's a very specific, detailed example, but that is what they're interested in. Is this process actually making the patient better, or have they reached maximum medical improvement? And maximum medical improvement is not fully fit. It's as good as we're going to be able to get them. We've tried this, we've tried that, we've tried this. This is as good as the technology that we have. This is all we can offer at this stage. That's maximum medical improvement. Over the next 12 months, they are unlikely to get a significant change in their range of motion. So let's say you've got a shoulder, they've got 120 degrees of abduction. You've looked at them, they're really stuck on 120. Are they going to get 180 in 12 months? Probably not, right? So that they have a mechanism to close the claim at maximum medical improvement. The other one for maximum medical improvement applies when they refuse treatment. So they say, I don't want to see the physiotherapist, I don't want a steroid injection, and I don't want surgery. So that means we've given them the maximum. We've given them the maximum that they're prepared to engage with, and so they can close the claim for that as well. So maximum medical improvement. And then the other one is stable and stationary, which I mentioned before. Stable and stationary doesn't mean they're better, doesn't mean they're cured. It means that they're unlikely to make a significant gain in the next 12 months. And that means for the purposes of the legislation, they are assessable. So we can now assess them as having an impairment. You've got a reminder on that computer. The caseworker is never expected to have any medical knowledge or training. I did work with a caseworker who was a physiotherapist, which was fabulous. She knew exactly what she was talking about. She'd been a physiotherapist in the past. She'd changed careers, but we really can't be expecting them to have any understanding of what we're talking about. We have to be clear with them about what we're expecting and what from our treatments, what we think is happening. And I've talked about the legislative requirements. That is, we really struggle because it's a legal definition. It doesn't have a clinical definition. So we all have a strong understanding about clinical terminology, but this is a legal definition. So fully fit. In Queensland, not so much in other states, they can go back to work even if they don't perceive that they're fully fit. So I have some young, strong men who are expecting to be, young and strong at the end of their claim, and I can let them go back to work before that, and I'm sure you guys understand that. They can often be a little bit stiff, but they can do their full hours. Sometimes they can even do their full duties, say if they've got a sedentary type of job. I do talk about the closing of a claim without a permanent impairment assessment allows them to have an injury at that location again. So if they have a back injury and they return to full duties and they're declared fully fit and they injure their back again, they can open a claim. If they have a back injury and they're permanently impaired, then that level in their back can never be funded for treatment ever again. Does that make sense? So if they have L4-5 disc prolapse and they receive a payout for that, it's like they go to work without an L4-5 disc. I find it very odd, it's a very strange sort of way of looking at it, but it's very challenging to open a claim for that down the track. Go on.
Sorry.
You had a question? Oh.
Yeah. I had a patient, she was coming from Woolies with the advocacy, not with the Workcover. She came like 3 months ago.
Mm-hmm.
They gave only 6 sessions, no more than that. She is good to go. Well, she had the pain at 5-6 level. No, we can't give anymore. It's fine. I tried to, but they did not budge. And after 3 months, she is back again with the 6 more sessions, and her pain is still at 4, still same area,
Yeah.
still having the shoulder pains. Can she go to the Workcover, or does she have to talk to the employer to go on the Workcover?
No, she does. So yes, she's allowed to go to a GP and try and make a Workcover claim.
Okay.
So in order to do that, she submits a medical certificate. Now, the secret is, at some point there needs to be some sort of documentation that she had an injury, right? Now, she could have injured herself at work and done an incident report. She could have injured herself at work and gone to the GP and said, I've got a sore shoulder.
Yeah.
She could have injured herself at work and gone to a physio and said, I have a sore shoulder.
Yeah.
So that injury needed to have been documented, and ideally they present to Workcover within 7 months of the injury. So it's nice if they do it within 7 months, but if there's documentation that is contemporaneous, it's different. It is well worth her going to a GP, completing a certificate, and then seeing what Workcover are prepared to say, right? Or they'll assess her. The fact that she's had an injury and then hurt it again at work doesn't necessarily mean she's had an injury per se the second time. They get confused because they know they've had a big injury at the beginning and then they've sort of exacerbated it or never actually got better. Right? So now there's 3 months in and they never actually got better. They don't quite know where they stand. But you're right, they do have a claim from the original injury. You've clearly documented the patient said blah, 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 blah. And so now they can address that.
And how about with the closing claim? If the patient is coming like for more than 1 year, she still gets, again, shoulder pain.
Yes, of course.
Around like in 20s or 30s PMP.
Yeah. Mm-hmm.
Still getting pain. She had detendinitis recently, but then she got tear in the shoulder.
Yes.
By 120, she goes like, pain gets started.
Sure.
180, pain is
She's
real.
great.
But she's there for like 14 months. She doesn't do exercises. How do you close that claim?
How do I close the claim?
Yeah.
That's a really good question. So you feel she's not participating fully in the process?
Exactly. Yeah.
Sure. And she's got ongoing restriction to her range of motion.
Yes.
I think, I guess I can only tell you from an orthopaedic surgeon's perspective. I will often see that patient come back for an assessment. How do I word that? So the caseworker can sometimes initiate an appointment with me, or the GP can obviously initiate an appointment with me, and you can have a conversation with the caseworker to initiate a referral. As you know, you don't really need me to make the diagnosis, and you know exactly what's going on, right? Yeah. But like I've said in this talk, is that I have very specific, legislative or professional requirements to document. And I might then be able to make it clear that there has been a lack of participation in the process. And I can, on initial consultation, I can say, look, this is as good as she's going to get if she's not going to participate. Do you see what I mean?
Yeah.
And sometimes that's, I think sometimes that's okay because the patient doesn't actually, if they're not motivated to get better and not motivated to participate in the treatment, which is perfectly fine. They may have other things that are more important. If they don't have the ability or the capacity to engage in the treatment, well then we need to stop and give them a break and maybe revisit it later. So yes, you could potentially close the claim, and then if she came back in 2 years or a year or whatever, having re-injured it or having had an acute exacerbation, then she may be more ready to address it. And I totally understand. Go on.
And how if it feels, because how about a psychological perspective, if it's more in her
okay, so if there's a psychological overlay, absolutely. So the typical example is someone who looks to me like they've had a really good physical recovery, but on the prospect of going back to work, they clearly have exhibit psychological distress. So I am no psychologist, and I'm very reluctant to diagnose anyone with any psychological condition, but I do encourage them to return to their GP and consider making a psychiatric plan. However, that is usually if there's been a significant trauma with, if they've had a very nasty process of being injured, it's quite important that they address that, because I can do all the exercise and the operations in the world and they just can't get past that psychological barrier, and that's very reasonable. Workcover does have what's called adjustment to injury counselling, so they are allowed to attend 5 sessions with a psychologist. It's not classified as an injury, it's not classified as a psychological injury, but they're allowed to get some assistance because this is a complicated process. It's going to be very confronting, and we can help them with that. So the caseworker can initiate that. I would think the physiotherapist can initiate that.
We can refer, but I'm fairly sure we need to run it by
you need to get an
customer
approval.
advisor.
Yeah.
We need to get approval.
So sometimes the patient will attend something like that and the penny will drop for the patient and they're like, oh, this is why I can't go back, and that's a service to the patient as well. Like why just do something that they can't absorb, or why offer a treatment that's not suitable for them. And the typical example is doing some sort of major orthopaedic procedure that you can clearly see that they would benefit from before they're psychologically ready. And I try very hard to avoid doing that sort of thing. We really need to get them on board psychologically before they take on another challenge, because there's the injury, and then there's the emotional burden, and then now there's the surgical injury, and then there's the physiotherapy burden. Do you see what I mean? So we need to have them ready to take that on. Go on.
No, that's exactly right. We screen. That's what we screen that.
You do some screening.
As and physios, that's kind of we're the people that pick up on that more than anything.
You will see it more than me because you talk to them more.
We've got a lot of time.
I do talk to them, but you've got more time with them.
And how about if their GP can say, let's say there's a patient, she's had like 4 times the work capacity, still not having the full range of movement or the ability to go back to her full duties, which is a very rarely night full duty.
Yes.
Has to carry up to 20 kilos.
Yes, I know, that's a heavy job.
So she's still not ready, but the GP told her on the last one that the next certificate is the last one I'm going to give you.
Oh, interesting.
So can GP do that?
I wonder. I guess from my personal philosophy is every time I see a patient, I take a history, I examine them, I make a diagnosis and I make a treatment plan. So I'm always reassessing them every time. So it's difficult to say what I'm going to say next time. But you're right, Workcover does often say, when are they going back to work? And I'm like, well, I need to know how they're coping. So I would imagine, so if the patient felt that acutely distressed about returning to work, they did not feel that they had capacity, I would encourage them to talk to their caseworker and say, look, my GP said this is what's on the cards. For the reasons 1, 2, 3, 4, 5, I don't think this is going to work for me. They do not encourage patients jumping from one doctor to the other. And they don't encourage them, as you know, jumping from one physiotherapist to the other. They get all confused about what the treatment plan is. But that might be in a scenario whereby the caseworker will say, look, let's get an independent assessment. So they go and see an independent orthopaedic surgeon, or they get a chart review, and let's see if the timeline is reasonable. And they may say, look, according to, we agree with the GP, this timeline is reasonable, we're going to close the claim. And yes, you're right, there is a capacity for them to do that. It's not an endless process. Yeah. So there is it's unusual though, I must say, very unusual. Yeah. So go on. No, it's not unusual.
No. Well, it is unusual for that for a GP, because there's so many things a GP could do in that instance.
Exactly.
Like, why are you not ready? Maybe we need to do a psych
true.
evaluation.
Exactly.
Is there other psychosocial factors that are the barriers which aren't being addressed in this treatment? There's lots of things, or even referral to a pain specialist prior to an IME.
Yes.
If the ortho says, yeah, it makes sense, GP says, yeah, it makes sense, maybe we need a pain specialist, because maybe there's other stuff at play. That the IME isn't a pain specialist half the time, they're not a physician. So they still will go, yeah, that's okay. Meanwhile, a pain specialist would go, yeah, there's lots going on here.
Yeah.
Or a psychiatrist.
Yeah, so they have got avenues. You know, I feel like sometimes they think that they've hit a brick wall, but there is lots of things that we can do. There's lots of pathways that they're not always aware of. And sometimes the caseworker is not kind of familiar with how that patient would fit that pathway.
Yeah.
Because they just haven't seen it as much as we have. That specific sort of injury. We talked about that. Fully fit. Northern Territory. Permanent impairment assessment. Permanent impairment is assessed by a specialist, that can be an orthopaedic surgeon or an occupational physician, to determine a percentage impairment. And I was explaining this to a patient who's had a meniscal tear. Okay, so he's had a meniscal tear and he's had a meniscectomy. So he's had a partial meniscectomy. So that number is 2%. I can't give him, if he's got full extension of his knee and full flexion of his knee, no muscle wasting, he gets 2%. You cannot give him any more, right? So I was trying to explain to him that it's a whole person impairment. So one arm is, say 20%, another arm is 20%, so a leg is like 20%, another leg's 20%. If you go blind, it's 5%, but it has to add up to 100. You can't get 110% whole person impairment. So at some point they very clever people have sat down and worked out, if you lose 10% of your range of movement of your finger, and then 5% of the movement of your wrist, then that adds up to whatever percentage impairment. So the patient will often question a percentage impairment, and I hear a lot of feedback, but I can't work. And I've got a 2% impairment, but I can't work. So they feel 100% impaired because they can't work. And that is a very different process. The Workcover insurance policy covers them for, if you think about it, you're insured for the different bits of your body. And at some point, you're allowed to lose them at work and get money for it. So if you have your finger cut off, there's a percentage, there's a number, there's an amount that your fingertip is worth. Which I think is a bit strange. I don't know that when I sign an employment contract that I feel like I'm signing a contract that if bits get removed, I'll take money for it. It feels like a strange arrangement, but I understand how it's come about. So it's related to range of motion. There is very limited capacity to assess pain, okay? Because pain is a subjective experience. It has a lot of emotional relationship with it. It is very difficult for us to assess pain, and we try very hard to not incorporate that within a Workcover permanent impairment assessment. There is no assessment of loss of income. That's not what this is about. This is about loss of a bit of your body, right? If the patient is interested in loss of income or loss of capacity to continue to work, then yes, I say go and see a lawyer. I don't understand this process. I am not capable of advising you. Because they sometimes will say, what do you think? What do you think? Do you think this percentage impairment is reasonable? Things like that. And I'm sure you're the same, I try very hard not to offer any sort of opinion because it is just way beyond what I understand. And so power is not assessed, pain is not assessed, for obvious reasons, because they're both subjective. Once they receive a payout, they're no longer insured for that body part, so when they get an amputation, we encourage them to have a payout because they're never going to need an insurance policy for their fingertip. And it's basically, in Queensland, they have a legislative requirement to return to work in any capacity. So if Workcover can get them back to work in any capacity, doing any sort of job for similar hours, then they are considered fully fit. Tribunal, the medical tribunal. Have you had patients go to a tribunal? Do you know what I'm talking about?
Yeah, vaguely.
Yeah,
It's been a while.
It's kind of at the very end of a claim. So when a patient receives a payout or an offer of a payout, they have an opportunity to request a tribunal assessment. And so basically the tribunal, like most tribunals, is looking at the process and making sure that the process was reasonable. So they had this injury and now they've been given this payout. Was that process reasonable? Now sometimes they don't really want to know whether or not the treatment was right. So I don't have to go in and work out whether or not their physiotherapy session was right, or whether or not they received the right operation in, technically perfect. It's about, with this injury, this assessment of their impairment, is that reasonable? The other thing that they go to the tribunal for is whether or not the injury is actually work-related. That's rare, I don't see that very often, but that's one of the questions that they can take to tribunal. Is this injury work-related, and therefore, are we going to accept this claim? So we have 3 specialists, and we sit behind a great big important looking desk, and we have a chair and we record it, and the patient sometimes brings an advocate, a person along with them. It's a little tricky when they've got to come all the way from Cairns. Often in Brisbane they'll have someone, their partner with them. And the patients, usually in Cairns, they catch the 6 a.m. flight in the morning, so if they're from out of town, in Beulah, say, they have to get up quite early. Catch the 6 a.m. flight, they go down, they have tribunal about 11 o'clock in the morning, they turn around in Brisbane and they come back again and then drive back to Beulah. So they find it quite fatiguing and it's very stressful. We can do a video tribunal, so in extreme cases we do a video tribunal. I find that very challenging because you lose that connection with the patient, and then we can actually manage a tribunal in Cairns in rare cases, less so now we're far from COVID. In my experience with the tribunal is the patient is generally asked to just tell the whole story again. Just tell the whole story. We don't care if it takes an hour, right? And they tell the whole story. I did this and then that happened and then my boss said this and then I went and had this treatment, had this operation, what date, what was the outcome of this operation. We try and listen to the entire story. So there's an opportunity for them to say their perspective on the experience. We get the documentation from the doctors, we get documentation from the MRI scans, we're allowed to review the MRI scans, but it's an opportunity for them to speak. Frequently patients after a tribunal will be disappointed with the outcome because they often have hopes that their case will not be, the legislation won't be applied to their case, if that makes sense. So the process won't be applied because they feel that there's something specific about their case that hasn't been addressed. So they will often come back from a tribunal feeling that they weren't heard, but we do try, not every tribunal, but we do try and listen to them, and then we try, but we have no opportunity to say anything about their treatment, and we have no opportunity to explain why, what's happened to them has happened to them. So there's no opportunity to have a conversation to explain the process to them. Lawyers, I think that the lawyers have been very supportive of me over the years. I often will refer patients to legal support when they become overwhelmed with the process. If they do not have the capacity to manage the process, for whatever reason, I try and encourage them to get support. If they can't read, if they can't write, if they haven't got family support, they're trying to struggle through it on their own, this is just a person who can also act as an advocate. I just remind them at some point, if they receive a payout, they have to pay back what they've received. So if they've received Centrelink payments or if they've received ongoing Workcover payments, then that comes out of their payout, right? So I try and say to them, is this actual appointment with me helping you today, right? Because I'm obviously not offering them treatment at that stage of the journey. I am facilitating their claim. So I try and encourage them to think about what that means. And sometimes the lawyers can look at things like costs of future surgeries, right? The lawyers do offer no win, no fee, but the legal fees are calculated out of the payout, right? So the Workcover payments come out first, Centrelink payments come out, legal fees come out, and then the patient receives the residual. Go. How am I doing for time? Woof, 7 minutes.
There's a question or a statement from Kerry regarding the return to work
Yes.
programs in the beginning. And she
yes.
said sometimes we need to be strict with employers and not let them push the employee inappropriately.
I've just had that this week. This guy, sheepishly confessing that he was absolutely not doing his return to work plan. He was doing much more. And, good on him for trying, but I agree with Kerry. They say, they do more than I've told them that I think they should be trying, and then they come in with pain. And I said, well, I need your pain to be dialed down so that I know what your functional level is, and then from that baseline we can build you up. And as Kerry says, if they feel obliged to do more, I agree. We have to sit down and we have another conversation. We talk about, why do you feel obliged to do more? Is this because you're terrified of losing your job, which is sometimes fair enough? Is this because you've got this special relationship with your boss looks after you, you look after your boss? Or do you just feel an obligation? Sometimes there's a personal obligation. People have strong work ethics, And so I agree with Kerry, trying to make them kind of look at their return to work plan and have that conversation with their therapist or with me to say, I'm not coping with this return to work plan because I'm doing more. And I give them an appointment 6 weeks later, but I do say, if you go to work and you heard it and they're asking you to do too much, can you please come back and let me know? And can you ring my reception? Can you email? Can you text? Can you whatever? Just tell me. And I'm sure you're the same. If there's a problem, you like them to contact you. So empowering them to do that.
And that can be a good indication for the Workcover customer advisor if they're not confident at communicating with the employer about the value of actually following a recommended clinical advice, is getting a rehab consultant in to provide further education and how if they follow the plan and trust the process, they're going to get there faster than if they push.
Yes, it's that boom and bust.
Yeah, education for the employer themselves.
Yeah, true.
So that they value taking it slow.
Yeah, but I think sometimes the employer gets overwhelmed by the fact that they've had an injury. Sometimes the employer is quite emotional that it's even happened. You can imagine you don't build a business in order to cut people's fingers off. It's pretty traumatic for the employer. And then sometimes they react in odd ways. They become quite distant or they become too involved. We sort of have to manage that process as well. And you're right, that the patient is managing the employer as well.
And it's a complex situation. That's where a third party
Exactly. I agree.
And an independent third party. So if the customer advisor is great, then it's not a problem. If I find the customer advisor is just very dismissive and not paying much attention to what the needs are of the worker, I'll recommend a rehab consultant to be able to be that third party. To offer that balance.
Is there a responsibility for the employer to at least educate the staff member on initiating a claim or something, or I can't remember, or like a HR department? They should, understand.
We should provide them information. And there's a helpline they can call regarding.
Go on. Tell me more.
I can't remember the name of the workline.
It's not the 1300 number for
Workcover.
The certificates.
I can't remember what it's called. Workcover Advisory Support Group, I think it's called.
Okay, yeah.
So I'm pretty sure that's who they should call to get advice. And it's not lawyers, my understanding is it's HR people, and they'll give guidance on what they could or should do. And then, but we have an obligation to tell them to go to their GP straight away and just check this out.
And have it documented at least.
And incident reporting as well.
Incident report.
Which straight away is
anything, even just an email to say, I tripped down the stairs on the way out from work today. Email. It's dated and timed instantly. And so it's the paper trail that's very helpful for a caseworker when they're trying to put through a claim. If you give them anything that documents it, then that makes it. But if it's just someone's recollection, I think Jimmy fell over on Tuesday, then that's hard.
Yeah.
Yeah, it's terrifying to hear the impact that the case notes of a clinician can have on someone's claim. From what
Terrifying.
lawyers have mentioned, how when they look through it and
Yeah.
say the EP says this happened, the GP says this happened, the OT says this, the physio says this, and if it doesn't match, they can kind of go,
Not consistent.
it's all inconsistent, none of it matches, Melinda, I'll see you later.
Oh, wow, I didn't know that.
It's kind of like the impression that I've gotten from some lawyers, in that they will see that as you've changed your story each time,
Wow.
so it's inconsistent.
Yeah.
When in reality, the clinician's like, I fell over, and the clinician's like, they tripped, or they slipped, or something different.
Yes.
And then that's just seen as inconsistent on the patient's perspective.
Yeah.
Which is concerning with more Heidi use, because Heidi is just sometimes awful at things like that. Because it hears,
doesn't have the ability.
and it can't discriminate between what the clinician says and what the person says. So if you're reflectively asking questions and to try and clarify what's happening, say you go, I fell over, did you trip? Did you slip? Like, what happened? It may then just pick one of them and go, tripped over, or whatever.
Yes, understood.
So
interesting.
if you're not reading it and making sure it's really accurate, the consequences for the patient is huge.
Yeah, the accurate document.
And that's based on information that we're told by lawyers. I know nothing about the law stuff.
No, same.
And they're great lawyers.
Yeah, but they need the piece of paper. And I think that's ultimately, and that's certainly something that we try to encourage. If there's a problem, you write it down. And that's something I had in my training program. Whenever I had a conflict, I would just write it down. Because nothing has value more than contemporaneous documentation. And it doesn't matter, you're upset at the time, you write it down, you forget about it. You trip over the stairs and you think, I think I knocked my knee. You forget about it, and then, a week later you're like, wow, what's this bruise on my leg? You can't even remember, because life, So I think that the answer is always, if you think something's happened, as an employee, you still write it down.
And there's merit in being validated and cared for and heard in an injury, in that it's less likely. Yeah, it's less likely for it to be them have something that they consider minor, but the employer dismisses it entirely, so it makes it feel even bigger because it's not a safe space, it's not a safe environment, and then you end up with a claim that probably didn't even need to happen.
Yes, I have seen that.
Psychological claim, or even just the injury progresses because of all the factors we know that can make an injury worse, from psychosocial factors, and then as opposed to, let's start some early intervention, let's make sure you're cared for, and then you got better. What are the chances of that? You didn't enter the system.
Intervention making people better.
Yeah, early, get it early.
Yeah, but you're right. We don't really talk enough about the factors around the injury that are, as you say, scientifically proven to prolong the injury, worsen the effects of the injury, worsen the perception of the injury. And there's simple things that we can change. Putting someone back into a supportive environment, putting someone into supportive host employment. I've had people really blossom in those scenarios. They've come from an employer that they were really struggling with. You put them in a host employment, they never want to leave,
Yeah.
I really like
Speaks volumes.
Anything else?
How do you approach a discrepancy with what your clinical evaluation is to what Workcover has their opinion on? So let's say your course of action for a patient is surgery for their best outcome, but Workcover is saying, no, we disagree. And then you have the IME, and then let's say that's also a different opinion. How do you navigate that for the patient?
So it's a best of three. It's like rock, paper, scissors, isn't it? It's best of three. So, which I find is very strange. So the treating doctor actually does have an opinion, holds a little bit more weight, right? So the treating doctor opinion, if they say they need operation X, that tends to hold weight. They then can have what's called a MAP review, which is where they have medical advisory panel. They send off all the pieces of paper to a doctor who can be anywhere in the state and say, what do you reckon, does this sound okay? So then that's a second opinion. I often find them challenging because the poor person that's reading the documentation is provided with a relatively skewed perspective in the documentation. So that can be hard for them. And then they have a third opinion, which is the independent medical examination, which is really probably required to be face-to-face. You know, you can do video, but it really needs to be a face-to-face assessment. So now you've got best of three. So the caseworker is entitled to take, you know, two opinions that say don't have an operation, but they have to come back to the treating doctor and say, what do you think? You know, and as you know, there's often a timeline on that. That's a very short return on that. You know, now we've had the IME, you've got 3 days to tell us whether or not you agree. So that can be challenging. And my approach to that has evolved a little bit. Sometimes the independent medical examination says, yep, that operation is reasonable, please proceed. Sometimes they'll say, that operation is not reasonable, you need to do this one. I find that a bit confronting, but I'm happy to take that advice on board, go back, examine the patient, assess the patient, and then sometimes I'll do that operation, but I can sometimes add on what I think is going on. I had one patient 2 years ago, and I didn't necessarily agree with that opinion, but then when I went back and examined the patient, she was able to articulate a little bit more clearly. She'd sort of, it's everywhere, you know, and she was able to narrow it down. She had a little bit of an experience with that doctor showing her where the source of her problem was, that she could then narrow it down, and she was happier to sort of narrow it down to that focus. I was happy with that. But if they come back with an absolute no, never, you know, terrible idea, I personally reflect on my decision. You know, did I think I had made the right decision? If I think that, you know, that is probably a reasonable approach. So sometimes the patient's got quite considerable degeneration, and the chances of success, so late cuff repair, the chances of success are actually quite low, and this surgeon says, don't do it, right? Then I'm much happier to sort of say, look, this is not going to work. You know, we asked Workcover if they were going to cover it. They've had an opinion which is similar to mine, which is this is probably not going to work. Let's not proceed. Yeah. And then sometimes I completely disagree, and I go crook and tell them that the other guy's an idiot. But I don't do that as much as I used to. So maybe I'm getting older. But you know, I used to say, you know, this is my decision, this is my assessment, this is what I think is going on. But now I find I've got a much better ability to be collaborative. I often disagree with that one, the paper one, because the poor person trying to do it, it's like trying to report an MRI scan. They've never seen the patient. So, yeah. All right, I think we're time.